Before we begin, I'd like to acknowledge the traditional owners of the land on which we meet today, the Bunurong people of the Kulin Nation, and pay my respects to elders past and present. So welcome and thank you for taking the time to meet with me. My name is Judy Clayton and I'm the spokesperson for the Koori Konversations project, a collaboration between the Dandenong District Aborigines Cooperative, Monash Health, the Monash Centre for Health Research and Implementation, and the Indigenous Advancement Strategy to improve access for Aboriginal people to mainstream health services. We've approached the City of Monash today due to your commitment to developing and fostering partnerships with community groups that involve and benefit the Monash community. The Monash Community Grant that we're seeking today will provide funding to deliver essential components of the KKP aimed at improving the cultural safety of their service. The Koori Konversations project came about due to a health needs assessment that considered the vulnerability of Aboriginal people relative to their access to health services, because one of the overarching issues of access was due to a fundamental lack of cultural safety within these services. What also became clear was that there wasn't any standardised or research data on this subject, and health services were unlikely to invest in new initiatives without having recourse to best practice evidence. From this, the DDACL approached Monash Health to support the development and implementation of a collaborative approach to improving health services access in a format that will be mutually beneficial to all stakeholders with a bottom-up approach to health promotion. We're excited about this project because it can create change on so many different levels, and I'll explain them as we go along. But most importantly, this has the capacity to break down barriers by empowering Aboriginal people to have ownership over health improvements and add to research that supports change through an Aboriginal lens. To understand the need for such a tool, let's take a look at a few of the statistics around Aboriginal people in Australia today. In 2012, Aboriginal people had an average life expectancy 10 years less than that of non-Aboriginal people. They were 4 times more likely to smoke during pregnancy, twice as likely to be unemployed, 3 times more likely to be the victim of physical violence, and 10% likely to be the direct victim of the stolen generation, and 15 times more likely to be imprisoned. They might also be representative of one of half of all Indigenous people aged over 15 years who had some form of disability. This is a very stark reminder. This is a very stark reminder of where we currently are when you consider that Aboriginal people represent only 2.5% of the Australian population, but they are up to 2.7 times more likely to die or suffer from preventable illnesses than their non-Aboriginal counterparts. They have an average life expectancy, as we said, of 10 years less, primarily due to non-communicable diseases. Additionally, suicide, self-inflicted injuries, anxiety such as depression, alcohol and drug abuse and autism represent 19% of the total disease burden for Aboriginal people. In comparison to non-Aboriginal people, Aboriginal and Torres Strait Islander people are more likely to have 10 times the rate of kidney disease, 3 times the rate of diabetes, asthma and heart disease, 1.6 times the rate of circulatory diseases, and twice the rates of restrictions such as physical disabilities. We could be forgiven for assuming that given this high burden of disease, that Aboriginal people would use mainstream health services more. But this is actually not the case. Aboriginal people might be sicker due to lack of cultural safety in hospitals in part, but are less likely to engage with these services sometimes until it is too late. So let's take a look at what this means and why this might be so. The statistics that I've just given you are only representative of one element of the problem. They are reminded of broader issues for Aboriginal people that lie outside the health system. The issues for Aboriginal people are an element of the social determinants of health. That's the social, economic, political, educational or historic factors that influence their capacity to engage with health services. For Aboriginal people, the social determinants of health have a history in the impact of colonisation and a long history of imposed intergenerational social disadvantage that's inclusive of these aspects: denial of citizenship, denial of pensions and access to employment, forced removals from families and traditional lands, and the legally sanctioned exclusion from society, voting, education and census, and marginalisation due to the past policies that have produced and entrenched systemically racist attitudes in healthcare, such as the stolen generation that's referred to in the image here. If you have a chance to have a read of it, I like the little girl in the centre of the group, but if taken by another, any of the others would do as long as they are strong. These can be linked to historic systemic discriminations resulting in Aboriginal people being denied the same opportunities to access health services as non-Aboriginal people. Studies for this extend from a lack of culturally safe healthcare services to discriminatory or racist behaviours by healthcare staff. This work will look at access in terms of cultural safety of a healthcare service. So what is cultural safety and what does a culturally safe health service look like? Essentially, cultural safety requires health services to undergo constant self-evaluation to ensure that they are meeting the cultural needs of patients and their families by ensuring that staff are not being influenced by pre-existing assumptions about a person's ethnicity, culture, social or economic background. For Aboriginal people, this means that health services need to recognise their definition of health as a whole life view, including the concept of life, death, life, and which lies in contrast to the traditional biomedical model of health with its focus on diagnosis, cure and treatment that predominates in the Australian context. Now that we know that to address access to health services and provide health promotion in line with the social determinants of health requires these things, let's take a look at what's been tried and what works. Aboriginal community-controlled health services such as DDACL, which is the logo at the top here, NUR5844 down the bottom, which is the National Aboriginal Community Controlled Health Organisation, the peak body for Aboriginal Community Controlled Health Services, and VACO, which is the Victorian arm, are agencies whose policies of cultural safety practices is compulsory for staff and volunteers and fundamental to the ethos of the provision of equitable health services. NUR5844 established protocols using best practice evidence learned from the health needs assessments of their own communities to create sustainable programs delivered in a holistic fashion on the premise that this can only be achieved by local Aboriginal people controlling the delivery of healthcare services. They identify that the community is responsible for determining its own needs to consider effective and appropriate methods to overcome health disparities based on the principle of self-determination using a bottom-up approach. One example of this is the Fetal Alcohol Spectrum Disorder Prevention and Health Promotion Resources Project, I know it's quite a mouthful, which targeted at-risk Aboriginal mothers or women of childbearing age delivered in a culturally safe manner by trained local staff, supported by evidence from health researchers utilising a systematic approach to achieve improvements in primary health care. What they did was establish specific, measurable, achievable, relevant and time-limited goals, SMART goals, from the outset, to reduce the impacts of FASD by developing and implementing a flexible package of prevention and health promotion resources. What worked for this program was the collaborative approach, with its success dependent on the development of positive and productive relationships with the ACCHS in that region, the Menzies School of Health Research, Department of Health and the Australian Government from community identified need. This determinants of health approach moved away from the concept of intervening to fix a situation from a top-down perspective, whereby the guidelines or policy will be generic with a one-size-fits-all approach to health promotion, to a bottom-up approach which took into account the requirement for flexibility in implementation of the resources to meet the needs of the communities in other regions as well, and began with an examination of one region to inform its use in other health services. This is one example, but this does not extend to mainstream health sector upon which Aboriginal people must rely. And what is problematic here is that there is insufficient evidence for mainstream health services to develop cultural safety programs. They want evidence that these work, and here is the problem. There is no mandatory reporting or monitoring on cultural responsiveness or cultural safety in mainstream health services. Cultural safety training programs are ad hoc in nature, unreliable, and not in line with the National Safety and Quality Health Service standards. There's no data collection and sharing is limited. Hospitals are left to develop their own approach, leading to fragmented efforts with limited resources. There's little or no collaboration or leadership, and there is limited or no Aboriginal input into their use. So what needs to happen? Leadership reforms to make sure collaboration happens, organisational change to ensure Aboriginal input into the creation of cultural safety training programs, and programs delivered by and not for Aboriginal community controlled health services. For mainstream health, there is essentially a lack of knowledge and education about Aboriginal people. In-house cultural safety training programs, as we saw, are short-term, ad hoc and superficial, and often leave health staff feeling more confused or guilty about their role in Aboriginal health, which actually makes the problem worse. Because they're ad hoc, they also have no long-term improvements with limited data. Universities are trying. They've introduced compulsory studies during undergraduate courses, but they don't take into account the prevailing attitudes and behaviours of existing staff. Clearly, there's a need for a systems change that focuses on the culture of the environment. Mainstream health services have also employed Aboriginal liaison officers, which is in part to support cultural safety, but there's confusion about their role and function of these positions, and they vary and are not standardised across organisations. There was a clear need for an empowerment approach to cultural safety in mainstream health services, using community participation, inclusive of research and data that informs practice, with collaboration across sectors. That's quite a mouthful, but what might this actually look like? We took all the issues we've just looked at and came up with a SMART objective, an objective that's clear, concise, amenable to evaluation, realistic, achievable to the issue, and with a time frame to match. We decided to improve access to mainstream hospitals for Aboriginal people with the development and implementation of a cultural safety training package for health professionals delivered by Aboriginal community controlled health services in a 2-year time frame. We want this project to be transferable, flexible and adaptable and across agencies and hospitals, so it's been designed with data collection built in. This parallel delivery of program and evaluation creates the building blocks for sustainable change with the creation of an evidence base for future programs. Essentially, the objectives of the program are to create an online cultural safety training package to be delivered at Monash Health, linked to their learning management system and included in annual compulsory professional development eventually. Include data collection tools so that there's routine collation of data that's transferable across services. Include education and training for Aboriginal people, and for the cultural safety training package to be included in evidence to support CPD training for all health professionals linked to their registration. To get there, we needed a great team. DDACL approached Monash Health, MCHRI and the IAS as they had demonstrated capacity to engage on these levels. They had established existing relationships or the capacity to develop one with DDACL as the lead agency. Monash Health in particular have a formalised dedication to improvements in Aboriginal health. Its Reconciliation Action Plan identifies cultural safety as a priority, and they already have a very formalised relationship with DDACL that goes back a long way. The Victorian Government Aboriginal Health Strategy, Cool and Barlett, is embedded in the Monash Health Strategic Planning priority list, with additional support provided by dedicated Monash Health human resources employees overseen by Aboriginal Principal Advisor in Aboriginal Health. They could bring expertise, funding and knowledge. They have a vested interest in systems change. They recognise access as the social determinant that drives the program. They have the capacity and time to engage with the program, and they possess good communication strategies with transparency of decision making to avoid conflict. Now, we put together some project logic. This is how we're going to get there. In collaboration, we put together a plan. The program logic which you have in front of you, and I'll be discussing now. But we forged ahead with what we have, so where are we up to now? This is essentially the first year. We've established the key stakeholder relationships that I outlined earlier, with each stakeholder contributing members to a steering committee. Under the Memorandum of Understanding we drafted, the steering committee will meet monthly and reports will be tabled as required, and this will ensure momentum and transparency during the project timeline for the IAS as the funding body. Early this year, all stakeholders attended a cultural safety training weekend. This was a fantastic way to build trust and gather momentum for the work ahead. Hosted by the lead agency, DDACL, and supported by VACO, this weekend created a great opportunity for them to retain leadership and control over the KKP process. VACO also sit on our expert advisory panel because they can provide education and training to Aboriginal volunteers and staff who will be working with the development of the online content. Monash Health have provided members of their HR team to sit on the expert advisory panel and will also support the development of the LMS component of the project. MCHRI have also commenced work on developing the evaluation, implementation and research tools with members of the expert advisory panel, and we have successfully implemented a timeline and working toward this. You can see that we are largely on track to delivering a community-supported, multi-sector health promotion program, and this is where we need your help. Funding for the project is largely supported by the IAS, but the crucial component of online content is not. We are asking for a community grant specifically for the development of this element of the project. The format of the online program is a before and after survey conducted when participants are challenged on their existing knowledge of Aboriginality and then provided with the virtual online opportunity to engage with a health service through an Aboriginal lens. They will then be asked to complete another survey to examine changes in opinions and attitudes. This evaluation method was chosen due to its ability to be integrated into the program design, provide responses in real time and inform potential issues requiring alteration and the early identification of trends. An integral component of this is the engagement of local community and strengthening of ACCHS, and we are now in negotiations with a local Indigenous media organisation to direct and produce the online tool we will be using for the project, using content developed by the expert advisory panel. At the same time, DDACL will provide education and training to its members who will be involved in the creation of the video and disseminating of the benefits of the program through Monash Health. With funding in place for the creation of the online media, the project will undertake an internal promotion campaign advertising the merit of completing the tool on the Monash Health LMS using incentives such as small prizes, vouchers, and utilising media booths where staff can confidentially complete the KKP in common areas of the hospital. DDACL and the local Aboriginal community will continue to be engaged in the promotion of the program for the 6-month rollout, during which real-time data will be collected to inform the need for adaptation or change. At 18 months, celebratory closing will be advertised and the results collated for the development of the findings and the formulation of results. To ensure the sustainability of the program requires us to revisit the reasons why the stakeholders were selected in the first place. This was essentially for their capacity to consider the program through an Aboriginal lens, that they are able to recognise and value diversity, be flexible to the needs of the Aboriginal community, and bring with them a proven suite of expertise, time and ability, and share a common goal. They must have the ability to work with DDACL and be responsive to conflict resolution. As important is the need for responsiveness during the project, which will be ensured with the provision of real-time evaluations conducted for the duration that will then inform the need for change and adaptation as the project is rolled out and allow for the stakeholders to celebrate milestones and data as it becomes available. Finally, long-term funding to sustain the project will not be forthcoming without a solid evidence base and ongoing and timely reporting mechanisms achievable through our Memorandum of Understanding and built-in real-time evaluation tools. We are excited about how far we have come on this journey. The KKP is a powerful project for equity through collaboration that aligns with the City of Monash values to provide funding to worthy groups who are making a difference in the community. This multi-sector approach will break down barriers by empowering Aboriginal people to have ownership over pathways to health improvements and add to research that supports change through an Aboriginal lens. We have provided the base and a dedicated team. We are asking for a one-off grant from the City of Monash for the creation of the online video content for the KKP using an Aboriginal specific media organisation. By providing us with the means is incorporating the City of Monash community values with those of the Aboriginal communities served by you. There are many ways to say thank you. Here are multiple ways to say thank you in traditional Aboriginal language and also in my own. Thank you.